Jamshed Dalal, who is the moderator, and all the speakers and panelists for this session. Dr. Reddy's as an organization believes in providing the innovative medicines to patients for the management of various diseases. And in this attempt, we are now launching sacubitril valsartan, which is a drug for heart failure where there is a significant mortality seen. And this drug was a blockbuster, which has shown reduction in the mortality, reduction in the hospitalization, improvement in the quality of life, and other symptoms and other features. So we are looking forward for an exciting sessions by the speakers, and this platform of diastology will be a live platform where we will be discussing the various new issues and the various factors in the heart management of heart failure. And this session is one of the first session in this series where we will be discussing on the ARNI as a forefront in the management of heart failure. So over to you, Vidya, for the introduction of the moderators and other speakers.
Thank you so much, Dr. Mustafa. On behalf of Dr. Reddy's, we are very honored to have Dr. Jamshed Dalal today with us. He will be the moderator for the event today, and he'll be also speaking on the topic ARNI, the right choice for HREF. Dr. Dalal is a senior international cardiologist and director for Center for Cardiac Sciences at Kokilaben Dhirubhai Ambani Hospital in Mumbai. He has over 40 years of experience in the field of international cardiology. He was associated with several renowned institutions abroad. And since 1987, Dr. Dalal has helped to establish the cardiology departments and interventional cardiology programs in leading hospitals in Mumbai, including PD Hinduja, Lilavati, and Bokar. He has several honors and awards to his name, such as the Cardiology Society of India Prize for Distinction at DM Cardiology, the Young Researcher Workers Award by the British Cardiac Society, and also been awarded as a Fellow of the Royal College of Physicians. Dr. Dalal practically requires no introduction, but with this brief introduction, I would like to hand over the virtual stage to Dr. Dalal.
Thank you very much, Dr. Vidya. I think it's going to be a wonderful session today on management of heart failure. And we're going to restrict ourselves predominantly on reduced ejection fraction, because preserved ejection fraction is a big topic by itself, and we can deal with that maybe at a later session, or if some questions come up, we will deal with that as well. We have got 4 wonderful speakers, and let me introduce them to you. First is Dr. Pondes. Dr. C.K. Pondes is a very old friend. We work together at the Hinduja Hospital, and he's presently the head of the department of the PD Hinduja Hospital. He's going to be talking on overview and challenges in heart failure. As you can see, next slide, please. As you can see, he's a gold medalist and a really brilliant speaker. You can see many awards to his name. And I see out here the Inspiring Cardiologist of India award in 2020, but I can tell you, he's been inspiring cardiologists much before 2020 as well. And I think the Economic Times woke up quite late in giving him this honor. So of course, the consultant cardiologist at the Hinduja Hospital, president of the Indian Academy of Echocardiography. So Dr. Pandey, always a delight to have you on our programs and to hear you. Though I've heard you so many times, you always tell us something new each time. The next speaker is going to be Dr. Prakash Hazra, with whom I've had plenty of sessions together. We've all enjoyed discussing topics, a variety of topics on heart diseases. He's from Kolkata at the Emory Hospitals. He's going to talk about the role of CRT and ICD, and I think it's an important aspect to discuss, especially in view of the recent drugs which produce a lot of improvement in heart function. And we're going to see where CRT and ICD still play a role in spite of all the 4 pillars of management of heart failure. So Dr. Hazra, please, next slide, please. So Dr. Hazra has a very long experience in Calcutta. As you can see, he's the head of the department in Kolkata. Lots of achievements, lots of medals, and he's been involved in a lot of experience and experimental and research trials, including in drug-eluting balloon, the ACS trial, etc. And of course, thousands of angiographies and angioplasties and pacemakers over the last 35 years. So again, Dr. Hazra, as usual, always a pleasure to have you on a conference meeting. Next, please. And then we have two panelists who unfortunately won't be speaking because of lack of time, but I'm sure they'll be giving their inputs into the discussion of heart failure. We have Dr. Viveka Kumar, is the senior consultant, both an electrophysiologist and an interventional cardiologist, and the director-in-chief of the Cath Lab at the Pan Max. And then we have Dr. Puranand, again, chief of cardiology and administrator of the Visionary for Improvement of Cardiac Care, and from Andhra. Next slide, please. Dr. Viveka Kumar is both an interventionist and an electrophysiologist, so it'll be nice to know about the electrophysiological aspects in addition to what Dr. Hazra will also tell us. Experience of thousands of cases of complex coronary angioplasty and even structural heart disease. And he's been the proctor and part of many, many training programs for complicated management of interventional cardiology. Next, please. The last but of course not the least, Dr. Puranand. He's established his own hospital, which we all know how difficult it is to do these days. He started with a 15-bedded hospital in Vijayawada, which has now become a 50-bedded hospital with all the possible facilities to manage cardiology from A to Z. And he has been trained in Rua with Dr. Alan Kripia, who we all have great respect for, the inventor of the TAVI program and the TAVI whole valve transplant program. And we look forward to Dr. Puranand's thoughts and discussions on heart failure as well. So we quickly move on now, to Dr. Ponde. And Dr. Ponde, I hand over to you to talk about your subject of cardiology before we actually move on to the treatment of heart failure. So over to you, Dr. Ponde.
Thank you. Thank you very much, sir. That was a very generous introduction. Thank you very much. Let me share my slides. Can you see the slides, sir?
Going to start, not yet. Yes. Yes. Please go ahead.
Have they gone on slide mode?
Now I can see both your small and slide both modes. So I think you can go into slide mode. It hasn't gone. Yeah, that's it. Now it's done.
Yeah. So as you said, sir, very you ease my tension because since last 7 days I was asking Dr. Vidya again and again whether this is heart failure in general or HEPREF. But I'm going to restrict myself to HEPREF because the entire program is HEPREF, and HEPREF is a topic of another day's conference. Maybe we'll have if Reddy's are interested later on with their molecule. So the universal definition of heart failure is HEPREF when you call ejection fraction less than 40, mid-range when it is between 40 and 50, and HEPF when it is more than 50. And now the current definition is more than 57% in men and more than 65% in women. So we are not going to talk about HEPF and mid-range. We are purely restricting ourselves to HEPREF population. The burden of heart failure is phenomenal. There are 21 million adults worldwide with almost 108 billion cost of healthcare worldwide for treating heart failure patients. Mortality remains high despite the guideline directed medical therapy, which is available, but which is not practiced as much as we want it to be practiced. And of course, comorbidities make the therapy complicated. What are the sad truths about heart failure in general? One in 5 men and 1 in 5 women have a lifetime risk of congestive heart failure. That is 20% of the population, adult population. And heart failure 5-year mortality approaches 48%, which is higher than leukemia, colonic cancer, and even non-Hodgkin lymphoma. So it's pretty dangerous disease. However, as we know that when we utter the term cancer, the entire family's eyes and ears, they are all eyes and ears to you. They're all antennae are open to listen to whatever you tell them to do for the patient survival. Whereas when you say heart failure, it says that they all say, no, कुछ नहीं, थोड़ी सांस फूल गई थी, ICU में 2 दिन भर्ती थे, अभी घर आ गए, अभी सब कुछ ठीक है. So the seriousness of heart failure is not understood by the families at large and even the patients for that matter, till they'll end up in recurrent hospitalizations. So heart failure is a progressive condition. Every hospitalization, there is a decline in quality of life and increase in mortality. If you look at all the pivotal trials of heart failure, 9 out of 10 patients remain symptomatic despite standard of care. nearly 1/3 of patients with heart failure are at increased risk of hospitalization, even when they apparently appear stable in inverted commas. There's nothing like stable heart failure. And if you see mean survival, after first hospitalization, 2.6 years, after second, 1.8 years, after third, 1.5 years, and after fourth, barely 1 year. So that is what heart failure is all about. Even mild to moderate NYHA class 2 patients. See, in class 4, they die mainly of pump failure, as we all know. When they come to class 2 and class 3, they die of sudden cardiac death. So 34% of NYHA class 1 and 2 died in 3 years, and 42% of class 3 and 4 died in 3 years in a clinical trial with a median follow-up of 3 years. If you look at mortality, on an average, a female patient will survive only 3.7 years after first hospitalization, and a man will survive only 2.3 years. So we'll come to this in a little detail later on about men versus women, the differences in heart failure outcomes. And there is an impact in quality of life. Almost 2/3 of patients with heart failure report symptoms that are consistent with depression, loss of quality, no sexual life, no productive life, and generalized lack of interest in life. The next question is prognosis of heart failure different in Indian patients? Oh yes, certainly. The mean age of patients in India is much younger, 53 years versus 73 years in Western world. Post-discharge mortality is 26% in India versus 9% in the Western world. And look at in-hospital mortality, 30% in India versus 4% in Western world. So the inter-CHF study, which was the earliest study done in this continent, showed that 23% of Indian patients with heart failure die within an year of diagnosis. And majority of that death is a cardiac death. This is the orange part of this bar diagram. Whereas in Africa, the majority of deaths are unknown or non-cardiac deaths in heart failure patients. The projected burden of heart failure in India is massive. And the two most important causes are uncontrolled, untreated hypertension and previous myocardial infarction. Valvular heart disease is taking a backseat at the current moment in etiology of heart failure in India. The Asian Heart Failure Registry was a prospective longitudinal registry in Southeast Asia. Proudly, our institute was one of the part of this registry, and we contributed almost 81 patients to this registry. 6,480 patients more than 18 years with symptomatic heart failure were recruited, and 20% had HEP-PEF, 81% had HEP-REF, and 1 year crude all-cause mortality was around 10%. So that is really a high mortality for this condition. What should I know about heart failure and diabetes? There are several pathophysiological mechanisms of heart failure in diabetes. Few amongst them, which are very common in clinical practice, is underlying atherosclerotic coronary artery disease, uncontrolled hypertension, structural alterations in cardiac myocytes called the so-called diabetic cardiomyopathy, and of course, neurohormonal activation of RAS system. We as students, and I know, we were all concentrating on microvascular complications like retinopathy, nephropathy, neuropathy, and macrovascular like MI, stroke, and peripheral artery disease. But heart failure was frequent, fatal, and forgotten. The prevalence of heart failure and type 2 diabetes. This is one study done in Australia and New Zealand continent, 605 patients with type 2 diabetes more than 60 years, primary care. Symptoms and signs and echo adjudication was done. So out of that, only 2.5% patients were diagnosed, 4.9, around 5% had HEP-REF, and 22% had subclinical HEP-PEF. So they're not even diagnosed. They just move around till they'll end up in hospitalization. In this, one of the wonderful studies done by Shah et al., published in Lancet, a large cohort of 1.9 million patients with type 2 diabetes, heart failure and peripheral artery disease were the two most common first presentations of type 2 diabetes. However, in what it surprises me that in the dedicated CVOT outcome trials of oral hypoglycemic drugs, The 3-point MACE is non-fatal MI, non-fatal stroke, and cardiovascular death. Heart failure hospitalization or incident heart failure is not involved or not counted, not even mentioned in a MACE. And I'm quite sure in years to come, a 4-point MACE will come as a 4th point as incident heart failure or newly diagnosed heart failure. There is an increased risk of heart failure in diabetes, no doubt about that. This is from UK database of 1.9 million patients. The relative risk keeps on increasing with increasing HbA1c concentration. And this is a wonderful slide. This will show you on the left-hand side the dedicated HEP-REP trials, right from Paradigm HF, Shift, HF Action, Senior, Soul, Merit HF, and CHARM added. In these trials, almost 30% patients had diabetes. And on the right-hand side are the trials of dedicated CVOT outcome trials of oral anti-diabetic drugs. In these trials, again, around 30% patients had heart failure. So heart failure and diabetes is a very, very close overlap syndrome. Diabetic cardiomyopathy is defined as a myocardial disease in patients with diabetes that cannot be ascribed to hypertension, coronary artery disease, or any other known cardiac disease. In this, there are metabolic effects on the cardiac myocytes because of free fatty acids. There is autonomic dysfunction. There is structural myocardial fibrosis with deposition of glycated aminoglycans in myocardial interstitium in these patients and reduced perfusion because of small vessel disease. Their epicardial coronary arteries all normal. They have no left ventricular hypertrophy. So this is a known proven entity. 50% of type 2 diabetes and heart failure have HEP-F and 50% have HEP-REF. Even in the biggest registry from our country, the Kerala Trivandrum Heart Failure Registry, 50% of patients hospitalized for heart failure had diabetes. So heart failure in diabetes is one of the most common cardiovascular complications, most disabling and deadly, very high rates of subclinical heart failure in diabetes, particularly HEP-F, and effects of oral hypoglycemic agents vary. So like glitazones are strictly contraindicated, they make these patients worse. And there are some other drugs like sexagliptin was withdrawn because of higher incidence of heart failure hospitalizations in type 2 diabetes. Does diabetics affect the prognosis? Certainly. Dysglycemia is a strong independent risk factor for cardiovascular death in HEP-REP patients. So it is associated with 30 to 50% increased risk of CV death as the CV death increases as your HbA1c goes higher. And is also an independent risk factor for heart failure hospitalizations. Then you will ask me, Dr. Ponde, that means, does excellent control of blood sugar alter heart failure outcomes? Unfortunately, this is a jigsaw puzzle. Intensive glycemic control was not associated with benefit for heart failure outcomes, except in one study, the famous UKPDS study. There were several reasons quoted for this. These were poorly conducted trials. The follow-up was poor. There were several dropouts, and therefore the trials got a bad name. But I am quite certain from my own clinical practice that excellent control of diabetes is vital for preventing recurrent heart failure hospitalizations and probably even increasing the survival. There is a poor prognosis in HEP-PEP and HEP-REP with diabetes. Whether your ejection fraction is more than 50 or less than 50, the moment your diabetes, your mortality goes on high. And of course, the Swedish Heart Failure Registry showed that median survival without diabetes is 4.6 years and with diabetes is 3.5 years in heart failure patients. This I'm talking about an overall population of heart failure, HEP-PEP, HEP-REF combined. But of course, majority of these patients had a HEP-REF. Then comes the next challenge for clinicians, managing comorbidities with heart failure. They are quite relevant. See, for example, obstructive sleep apnea, COPD, which might prevent you from giving targeted doses of beta blockers, renal dysfunction, which may prohibit or limit the effects of loop diuretics when they come in acute decompensated phase in the ICU. And of course, diabetes, which I already highlighted quite much, anemia, potentially treatable, and obesity. So which comorbidities make a difference? Out of cardiac comorbidities, 2 comorbidities which are perfectly treatable and make phenomenal difference in the outcome is treating underlying coronary artery disease with appropriate mode of revascularization, and aortic stenosis, which is severe, treating it by either surgery or transcatheter aortic valve replacement. In non-cardiovascular comorbidities, 3 of the most common and most treatable are diabetes, chronic kidney disease. Now with SGLT2 inhibitors, the outcomes of CKD with heart failure have improved phenomenally with empagliflozin and dapagliflozin. And of course, with AFFIRM trial, the iron deficiency correction has clearly shown that outcomes improve, both in terms of hospitalization and heart failure. There is a prevalence of kidney failure in patients with heart failure. Almost 1/3 of patients have chronic kidney disease and 1/5 have worsening renal function just before admission in acute decompensated phase. And CKD increases mortality, increases hospitalizations, and worsens the quality of life. Let us see how was the journey of RCTs in heart failure. Right from Valeth to Atlas, we had from 1986 to 2001, and Copernicus with carvedilol, Merit heart failure with metoprolol, and CBIS 1, 2, 3 with bisoprolol. And then we had a long hiatus of 10 years. And then we had emphasis with eplerenone, paradigm with ARNI, DAPA, HF with dapagliflozin, and Emperor reduced with empagliflozin. And therefore, now, in the olden days, we had beta blockers, ACE, ARB, and MRAs as the foundational pillars. Now we have ACE and ARB replaced with ARNI, and we have DAPA and EMPA as additional pillars for treatment with heart failure. So these are called now Fantastic Four by the experts and tolerers like Scott Solomon, John McMurray et al. Mineralocorticoid receptor antagonists, ARNI, SGLT2 inhibitors, and beta blockers form the foundational 4 pillars of heparin therapy. However, the sad news is not even 20% people leave the hospital with guideline-directed medical therapy in an appropriate manner. And not out of those who leave the hospital with GDMT, only half of them stick to it by 1 year. So this is a huge gap between the guidelines and the clinical practice. For example, in a 55-year-old man, a comprehensive GDMT will improve event-free survival by 8 years and overall survival by 6.3 years. That's a huge gain. But there is a therapeutic inertia, and this inertia is phenomenal. Look at this one registry which showed that at discharge, the target dosages with ACE, beta blockers, and MRAs are no different than at 1 year. So we don't do much after discharge. Maybe patients are lost for follow-up. Maybe we have inertia. Maybe we don't call them frequently enough to titrate the dosages. And this is the Canadian registry again, which showed that in ambulatory heart failure patients, look at the targeted doses, this at target dose, 38% with RAS blockers, 30% beta blockers, 40% MRAs, and hardly 10% with ivabradine. So we are not doing enough. We are just not doing enough. And therefore, the mortality in HFrEF remains high despite introduction of these therapies over 20 years. Therapies are there, my friends, but we are not giving them appropriately. We are not titrating the dosages. Then therefore, 5-year mortality remains 40%. One very peculiar thing is electricity in heart failure, charged with sex discrimination, as I call it, because CRT favors women more than men, and not one. 2 trials have shown that, and Dr. Hazra will probably throw a lot of light on this discrepancy in CRT outcomes in women versus men. Even women with ICD get fewer shocks. God, Are only men supposed to get shocks in this life? God only knows. And women have better heart failure survival than men. So a large meta-analysis has shown of 31 studies of 41,000 patients that women with heart failure have better survival. I don't know why. There are several hypotheses. I will not go into details on that. I know my time is running out. I have 1 minute left. Sudden cardiac death is another challenge. So you take the patient from acute decompensated place to class 3. You move this patient from class 3 to class 2. Then is the time to decide. After 3 to 6 months of excellent guideline directed medical therapy, if your ejection fraction is not above 35%, please address the risk of sudden cardiac death. And Dr. Hajra is the brilliant man, brilliant speaker. I'm quite sure that he will throw enormous light on this aspect of heart failure therapy. So the recent news, a first man receives a heart from genetically altered pig. So Norman Shumway said, xenotransplantation is the future and always will be. And maybe we'll survive to see that a lot of people will get pig's heart to survive the HEPREP battle. Thank you for your patient attention.
Thank you very much indeed, Dr. Pandey. That was beautifully covered. We will now move on with my talk on how to manage these patients and the problems. You heard Dr. Pandey talk about all the issues that happen and how important it is for drug therapy, because the prognosis and the outlook is so poor in these group of patients, so that we really need to do as much as we can. And as you will see later on when we discuss, we're simply not doing enough. Now, we know that before the paradigm trial came, which is today, I'm going to concentrate on two aspects. I'm going to talk about reduced ejection fraction, not go too much into preserved ejection fraction. And I'm going to restrict my talk to ARNI and not really going to talk of any of the other managements of heart failure. So a very restrictive talk specifically related to the beneficial effects of ARNI in heart failure with reduced ejection fraction. Now, when paradigm trial was done, as you can see from here, that the group which was on enalapril, it was enalapril compared to ARNI. And the enalapril group showed a very significant percentage of patients, in spite of being on enalapril, had CV death and heart failure hospitalization as the first event. And Dr. Pandey has been saying again and again about sudden cardiac death, and sudden cardiac death manifesting as the first event was as high as 11%. So do remember 2 points. One is that patients in class 4 heart failure will die with heart failure, but those in class 2, class 3, the so-called stable patients who we think are doing well, actually die very suddenly with sudden death. So please keep that in mind when you're treating these patients. Now, ARNI was a beautiful drug which is now available for quite some few years. It has got both effects in terms of RAS blockade and all the harmful effects that happen with RAS stimulation. And on the other hand, you have ARNI and all the beneficial effects of the enhancing vasorelaxation and all the effects in terms of natriuresis, blood pressure reduction, for fibrotic reduction, reduction of aldosterone, sympathetic tone. So the combination of enhancing and inhibiting with sacubitril and valsartan is indeed a dramatic new development in the management of heart failure. If we look at the paradigm trial, which is now quite a few years old, 2014, you can see it's a large trial, a group of patients, about 64, mostly men, and as you can see, female prognosis is better. So this group of patients with almost 60%, 80% men would have much worse prognosis. Again, you can see patients with hypertension, diabetes very high. You can see that they were predominantly class 2, class 3 patients, not class 4 group of patients. Ejection fractions less than 30%, so pretty sick. 60% were ischemic, 40% were non-ischemic. Important to remember that. They were on very good treatment at the start of treatment. So please remember, extremely good treatment at the start of treatment. As you know very well from the paradigm results, that there was a significant difference, and you can see this p-value with so many zeros suggesting an extremely important positive response. And again, please note a very early separation of the curves. So that's 2 points to remember: extremely beneficial effect and very early separation of the curves. And if you look at the two separate aspects of it, if you look at sudden death and if you look at worsening of heart failure, again, you can see again the dramatic reduction of sudden death and the significant benefit in terms of further worsening of heart failure death. So in terms of sudden death, or worsening heart failure death, both of these modes of death were significantly reduced. And again, a significant 16% reduction, a very good p-value in all-cause mortality. Now, it's very difficult to get reduction in all-cause mortality with most of the trials. Yes, you may get reduction of hospitalization, reduction of cardiovascular events, reduction of cardiovascular mortality, but getting an all-cause mortality really takes into account the totality of the management of the patient. So the good effects, the bad effects, the comorbidities, everything is taken into account. And when a drug produces a reduction of all-cause mortality, it's really a great drug. Now again, valsartan and sacubitril combination have multiple effects in terms of myocardial stretch, inflammation, fibrosis, neuronal activation, and each of these can be detected by various biomarkers. Now, we don't often go around measuring aldosterone levels and other factors. We do ST2, which is a very powerful and good marker of prognosis, better than NT-proBNP. But of course, the most common biomarker we use for diagnosis and to some extent for prognosis and to some extent for management of these patients is the NT-proBNP. So almost everybody will have an NT-proBNP value for both diagnosis and for the management of these patients. Now, if you look at the NT-proBNP value in the paradigm trial, you can see again a significant reduction of the NT-proBNP. And we know very well that as NT-proBNP falls, the patient symptomatically improves and prognosis improves. And we often base our treatment or to some extent alter our treatment depending on this fall in BNP. So if you have a patient who comes to follow up and has a dramatic fall in BNP, you're doing the right thing. If BNP does not fall or if BNP rises, you need to clearly look at this patient very carefully because you're not doing something correct. And again, if we look from the Pioneer trial and look at the change in NT-proBNP, again, you can see a very significant early fall. So important aspect to point out is the early widening of the curves for mortality and primary endpoint, the early drop in the BNP, the early differentiation of hospitalization, rehospitalization with sacubitril valsartan. And I keep stressing that point early because we know now that when you treat patients with heart failure, you must treat them early, not necessarily in the ICU when they're on intravenous diuretics, but as soon as they get shifted out of the ICU, before their discharge, and we'll talk a lot afterwards in the discussion about what time and when we should start. But clearly the important point to remember is that the treatment must be started before they leave the hospital. There are a number of advantages. One is that you know the patient is getting the drug. You know if there are any side effects that develop while the patient is in the hospital. The patient gets used to the drug and doesn't get worried about taking in the OPD. If you do not start the drug in the hospitalization period, patient may not get the drug, patient may not see a month after the admission, and then we miss out the crucial vulnerable part of heart failure, which is the first, say, 30 days after discharge from the hospital or after the acute heart failure. So very, very important, not just ARNI, but as many drugs as possible to be started as soon as possible, preferably before discharge of the patient. As you look at further aspects of this paradigm trial, you can see whether you are young or old. So even above 75, you get benefit. Whatever the ejection fraction, very low or not so low, whatever is the GFR, whatever is the systolic BP, and whatever is the NT-proBNP, you get benefits across the board. So you really don't need to restrict yourself to any particular subgroup of patients because throughout all the subgroups, ARNI is very beneficial. Again, very interesting. Hospitalization reduction is a very important part. And Dr. Ponde clearly mentioned to you, repeat hospitalization means early death. And here you can see that when you look at enalapril versus ARNI, hospitalization for heart failure overall or 30-day rehospitalization or emergency visit or total hospitalization for worsening heart failure, all are reduced. So every form of hospitalization is benefited with ARNI. So ARNI will benefit when you have ambulatory, when you're in hospital, and even advanced, because as soon as you finish the advanced aspects, I do not think that we need to start ARNI when patients are on inotropes. But as soon as they're off inotropes, preferably off the intravenous diuretics, immediately starting this treatment will prevent, one, the first hospitalization and the recurrent hospitalizations, eventually leading to a significant reduction in heart failure death. Very important to remember. All of you have seen this diagram. We use ARBs, we use ACE inhibitors, but when we shift to ARNI, you get a further significant benefit above and over what you would get with ACE inhibitors. So please remember, when you're talking of ARNI, we're not talking against placebo. You're talking against a well-established therapy of ACE inhibitors with enalapril. Of course, the major dramatic things that we saw with ARNI, and this is something which really pleased all the cardiologists, is the reverse remodeling. Reverse remodeling means improvement of the poor ejection fraction. And that's something which struck us right in the face as soon as we started using ARNI. Two things struck us. Number one, this tremendous symptomatic improvement of the patient. So however expensive the drug may be, when they came to us at the next visit, they told us the drug is expensive, but they also said that we feel so much better, we are unlikely to stop the drug, whatever may be the expense. So the tremendous symptomatic improvement was one thing which struck immediately. And the second thing which struck was improvement in ejection fraction. We nowhere had anywhere a drug which actually improved ejection fraction. Yes, ACE inhibitors, ARBs helped. Yes, there was a little bit of benefit. Yes, beta blockers were good. But this dramatic improvement of ejection fraction was something which we had never seen. And it's important to remember that when we talk now of ICDs and CRTs and even transplants, patients kept for CRT, patients kept on transplant lists have actually now been able to withdraw a certain percentage of this, because while they were waiting for transplant lists, while they were on ARNI and other drugs, they improved significantly not to require transplant anymore. So dramatic changes that we can see, and you can see here the improvements in ejection fraction, the improvement in end systolic and diastolic volumes, left atrial volume, everything significantly reduces. As you can see, improvement in ejection fractions of 9 to 18%. And this is something which we don't see with any other drug. And I've seen several patients, and I'm sure all of us here who have used ARNI have seen this. And I think this is one of the most dramatic things that I feel happens with ARNI. If we quickly shift, I know we won't talk about preserved ejection fraction, but Paragon was with preserved ejection fraction. Of course, what they actually meant was over 45. So they included mid-range, or what is now called the mildly reduced ejection fraction. And you can see that when the ejection fraction was less, that between 45 and 55, they benefited. When the ejection fraction was very normal, above 60, they did not. So even in this mildly reduced ejection fraction, it is beneficial. When I spoke about ventricular remodeling, there are various reasons for this: afterload reduction, reduction in mitral insufficiency, changes in the extension of myocardial infarction, reduction of aldosterone, reduction of hypotension. So many factors which produce this benefit of remodeling. Of course, there's no doubt about the quality of life improvement, and that has been seen very early in these patients, so very rapid improvement. And we saw this as soon as we started the patient. You gave the patient this ARNI, we were scared about it, we had just started using it. 2-3 weeks later, when the patient came back for follow-up, he said, I feel so much better. My goodness, I feel so much better. And that was absolutely seen in the trials as well, the dramatic early improvement in symptoms. Dr. Ponde has spoken many times about sudden death, and I think it's important to remember that we have now a drug which reduces sudden death. So that's clearly very important. There are so many patients who need ICDs, but we know in our country, ICD implantation is not that common. Cost is a problem, hesitancy is a problem, but a drug which reduces sudden cardiac death is very important. Again, as Dr. Ponte pointed out, sudden cardiac death is common in class 2, class 3, the patients who look good, the patients who are walking, talking, working, who come to you and say, I feel good, doctor, they die suddenly. And giving this drug to these patients will reduce the sudden death. So you have to explain to the patient that you feel very good, but it's still important to take because your chance of sudden death will be significantly reduced. And now, in fact, if you look at the guidelines, the use of the drug is a class 1 indication for class 1A indication for sudden death. Again, the important point is to use the opportunity of improving these patients. So start early. So the time to start is not afterwards when the patient comes at the first follow-up or later. Start right here at the point of admission. As soon as the acute phase gets over, that's when your trajectory of treatment starts. Right now, transition to oral therapy. Start all your therapies. Gradually increase the dose. We can discuss about which drug first, what dose is first. But before the discharge, patients should preferably be on all the 4 drugs and definitely on ARNI as well. So optimize your treatment as soon as possible. If you look at the patients with acute heart failure, now we move on to Pioneer trial, which is acute heart failure, because the question in Paragon trial was these were chronic patients. So we kept saying use early. Is there data? So here's the data. Pioneer trial. We have Pioneer trial, the transition trial. Many trials showed that early use of ARNI substantially benefited these patients in the long term, and it was safe. Very important to remember that safety is also an important factor. So if you look at the latest 2021 ESC guidelines, ARNI, along with beta blockers, MRA and SGLT2 from the absolute cornerstone of starting treatment for this patient. I would like to talk about the 2022 AHA heart failure ACC guideline because they just came out actually, I think this week or last week. And I think we should quickly go through this because it's very important to stay up to date. So if you look at the 2022 ACC American Heart Guidelines, you can see that class 1 indication for the use of ARNI. And again, ARNI is to be used only for every patient, and AC inhibitors are to be used only if ARNI is not feasible. That means if you cannot absolutely afford ARNI or you cannot not available in your country, then you use AC inhibitors. Otherwise, this whole question of using AC inhibitors and then shifting to ARNI, which was what the earlier guideline showed, is clearly not to be followed. Now, why do we choose ARNI first? Very simple. There's no biological possibility to sequence ARBs first and ARNI afterwards. There's just no sense in that. Second, they're going directly to ARNI is well tolerated. There's no problem. There's nothing that patient will tolerate AC inhibitor and then give ARNI, it will be tolerated better. The benefit of ARNI appears very early, so you don't want to waste your time with AC inhibitors. Waiting to start ARNI actually reduces the likelihood that the patient will actually change from AC to ARNI. Waiting for failure of AC inhibitor is completely unjustified, and ARNI therefore remains the straightaway drug of choice in patients with heart failure. Again, ARNI instead of AC inhibitors provides a high economic value, so don't look at the cost itself. Over the long period of time, the cost that you save by using an AC inhibitor instead of ARNI will more than be lost in the repeated hospitalization, the poor quality of the life of patient, and of course, death as well. And harmful, ARNI should not be administered within 36 hours of the last dose of AC inhibitors. The patients on ARB, you can start immediately, but because of probable increased incidence of angioedema, if the patient's on an AC inhibitor, wait for 36 hours before you start. Again, if the patient has a history of angioedema, be very careful, and class 3 indication harm. So quickly, I don't want to go through this detailed slide. This is the stage C and D, heart failure, reduced ejection fraction, the very recent last week guidelines, all the 4 pillars of drugs. And then of course you have other drugs, hydralazine nitrate combination, ICD and CRT, Dr. Hazra is going to talk about. And of course, transplantation always remains a possibility. A quick word on mildly reduced ejection fractions is between 41 and 49. Class 1 indication, diuretics, 2A, SGLT2, ARNI 2B, MRA 2B, and beta blockers 2B. So ARNI, MRA, and FREF beta blockers remain 2B, 2A for SGLT2, and of course diuretics for symptomatic improvement. And if you talk of patients with preserved ejection fraction, which as Dr. Ponde mentioned, over 50%, diuretics, of course, for symptomatic improvement, and the same, SGLT2 2A and all the other drugs, including ARNI now 2B, for these patients, even with ejection fractions above 50%, last week guidelines. And again, patients with improved ejection fractions, those are the patients whose ejection fractions were low, below 40%, there's a 10% improvement, and now the ejection fraction is more than 10%. So 30% becomes 40%, so 10% improvement, or 40% becomes 50%, and the ejection fraction is more than 40%. They're called as improved ejection fraction. Very, very important. All drugs should be continued in these patients, and no drug should be stopped. So please do not stop the drugs when the patient heart function improves. Again, we've spoken about this many times. Patients with class 2 are often not very symptomatic. They're comfortable at rest. They hardly have any symptoms. Mild symptoms does not equal to mild disease, does not equal to stable heart failure. So please remember, do not say patient has no symptoms, therefore patient has mild disease, patient is stable, and therefore I will not start ARNI or I will not give ARNI. Please do not do that. Now, many times we say a patient is hypotensive. Now, that's an important problem. Patients do have low blood pressure when they start off and do fall in blood pressure. So that is a problem, and we see that very often, and we need to look at that. But clearly, if you see discontinuation of ARNI is same as with enalapril. So really, AC inhibitors are no better. And in fact, patients with hypotension on ARNI will do better, in fact, with patients than on patients with hypotension and enalapril. So yes, blood pressure may fall. Watch the patient closely. Look for orthostatic symptomatic hypotension. But please do not stop the drugs. Yes, you may reduce the drugs. More important, what you need to do. And again, hypotension is not a concern only with ARNI. As you can see, all the other drugs, including beta blockers, will produce blood pressure. So this production of hypotension is a problem in the management, and we need to know how to deal with it. And again, if you look at sacubitril, it scores over enalapril with low BP. So when you have low BP, it is still better. For example, BP less than 100, sacubitril still does very much better than enalapril. So low BP should not be an excuse for not giving ARNI or for continuing ACE inhibitors or ARBs. And what should you do when the blood pressure gets low? First, of course, monitor them. Secondly, look at other things. Patient may be on too much diuretics. Try and see if you can get the patient completely off the diuretics. Sometimes I've seen patients, they're hypotensive, ARNI is stopped, but they're on an amlodipine or some other antihypertensive drugs. So please stop all other antihypertensive drugs, reduce or cut down diuretics completely, more so if you start SGLT to avoid any hypovolemic situation for the patient. And then, of course, in case after that also, the patient BP dose remains low, you can discontinue briefly, temporarily, or reduce the dose. Permanent discontinuation therapy is usually not required because eventually the heart function will improve, the blood pressure will improve. If you don't treat them, heart function won't improve, blood pressure won't improve, and they'll spiral into death. Also, the benefit of neprisilin and ARNI in management of renal function. I won't go into too much about that. There's always an initial rise of creatinine. That means that there's an initial fall in creatinine clearance, but eventually over the long run, the kidneys benefit. So kidney function deteriorating temporarily should not again be an indication for discontinuation. And now we all know that when you look at death, heart failure, hospitalization, all-cause mortality, those patients who are on treatment, even the early treatment, but now even more so with the use of ARNI and SGLT2, the difference between those on treatment and off treatment is dramatic into the number of life that you will save for these patients. In spite of hundreds of lectures that Dr. Ponde, I, and Dr. Hazra, and all of us have given so often, we still find that people simply are not on drugs. This is only one of many trials which shows that a large number of patients really are not on adequate drugs. And this is more so in India. And of course, one of the ways to improve that is to have a checklist. And we could talk about the checklist as a subject, in fact, by itself, how important a discharge checklist is in the management of heart failure. So you don't need to necessarily have a big heart failure clinic. Everybody should have a heart failure clinic. But I think in my mind, heart failure clinic should be in your head. That's all you need, a heart failure clinic in your head, where you have the checklist in your head or on the paper. Better to have it, of course, on a piece of paper. Go through the list of what is missing, why it is missing, what is the dose. Significant improvement of treatment happens when you have the checklist in front of you. I won't go into details because you're not discussing all aspects of heart failure treatment. Should we start all the 4 drugs in small doses? Should we maximize one with the other? We can discuss that. But the present approach is usually to try and get all the 4 drugs in as possible, as quickly as possible, maybe even in small doses, and then gradually increase the thing as much as we can. So friends, I've sort of rapidly rushed you through all this because it's too vast a topic. And we'll be short of time. So I think we'll move on quickly to Dr. Hazra, who's going to talk about ICD and CRT and the importance of these devices still in spite of all the treatment. So Dr. Hazra, over to you. Thank you very much.
Thank you, sir. So I'll be speaking on CRT, the ICDs in the treatment of heart failure. And the things are progressing and improving every day. The new technology, new targets, and new success are coming, be it drug, be it device. And you know that the heart failure with reduced ejection fractions have many varieties, and there are many imaging modalities, including amyloids to the heart, which can beat your heart so badly. And there are therapy like pharmacotherapy, which can make your heart better. And sometimes you don't need any other thing like ICD, CRT, CCM, or any costly device like LVAD or transplant if you have a good drug for good durations, adequate doses. Now, heart failure is a disease of many American presidents, and there are differences between racial outcome, men and women. For example, the men are more prone for VTVF. The women start their heart failure with higher ejection fractions by about 5%. They are better responders to your CRTs and left bundle branch pacing or any other pharmacotherapy, because these drugs, they are working on different levels, and perhaps there's some mechanism which separates or divides men versus women. But for the timing, that all men and women should be treated equally. And most of the time, this heart failure is the first time heart failure in the lifetime. It is frequent, and sometimes it is forgotten, and sometimes it's fatal. So this decompensated heart failure, once they get adequate medical therapy, or those who develop the complications or deteriorating heart failure, in spite of good dose of full fabulous foundational drug in 2022, they need some kind of device, and all depends on the ejection fractions number. Now, heart failure is divided into two groups, as Dr. Dalal was mentioning, the REP or not in REP by 40%. After this trial with SGLT2, now we know there are two types of heart failure, mainly either even reduced ejection fractions or not in reduced ejection fractions. So this dividing line has prohibited many CRT or CRT-related device to be advocated for patients who has got little higher ejection fractions and very symptomatic, but they are prohibited by ejection fraction number. Now you have less than 25% like Copernicus, we have Meditra less than 30%, less than 35% you have many drugs, less than 40%, more than 40%, you have less than 45%, more than 45%, and unknown ejection fractions. But we are moving towards more towards a global longitudinal stent pattern. Now, this is the summary of your available therapy, which will be available in the next decade, next 10 years. So your foundational therapy starts with these drugs, and some of these drugs, like SGLT2, does improve ejection fractions. So 35 becomes 40, 40 becomes 45. So if your ejection fraction is improving, you may not need CRT. If your ejection fraction is improving by ARNI, you may not need CRT or L-via transplant. So these drugs are working as cellular ICD or pharmacological ICD. Then you have these drugs, we have many rehab mechanism, and people do need all sorts of therapy, rehab, drugs, device in a continuum in their lifetime. As I see the heart failure therapy, the centerpiece is loop diuretics. Nothing can beat loop diuretics as per the rapidity of symptomatic relief in your ICU congested state. But the second line of defense is formed by these four fabulous foundational drugs at 4 to 6 weeks. You can start with MRA, you can start with ARNI, start with beta blocker or SGLT2. There is no more state care approach as we have learned in last few decades. So this is a circle, and the second circle is formed by omecamtiv, bericiguat, ivabrudine, IV iron. So you have, once you have these drugs, then you go for this device. Now, this new device like CCM and CRT, LVV zone pacing can be advocated even if you have ejection fraction a little on the higher side. If you have a regurgitation valve, then you can always go for a mitral clip. If you have aortic stenosis, go for TAVR. So that will relieve your reduced ejection fraction, make them better. Now, the penetration of drugs in these trials, with the device CRT trial, if you try ARNI in Novartis, the use of drugs, other drugs is little less. Similarly, vice versa. If you try SGLT2 trial, if you go to the SGLT2 trial, the use of ARNI will be less. Even then, you know that if you use these drugs, the number of shocks or the number of arrhythmias is reduced, like SGLT2. So these are basically working as pharmacological ICD CRT. So if you introduce them early in your lifetime, these patients may not need the costly device like ICD. So this is the history from 1947. We have moved to the subcutaneous wireless ICD, and this is supported by many trials. And you have more data with the newer therapies, as I mentioned, the clips. But one device will not be seeing the light of the day once you have this ARNI and SGLT2. So this SGLT2 has killed the intra-atrial shunts, but we have other drugs, and there will be many drugs, and these device and drugs should give adequate support. And this device like CRT or ICD should not be producing any complications, and should be placed not too late in the course of therapy. So it is not advocated in patients who are having life expectancy less than 1 year. So it should be early if somebody needs it. And sometimes you have to combine this ICD with CRT, LVP with CRT, hot CRT, lot CRT. Now, there are divisions of therapy or segregations of therapy on your QRS. That is the most important factor. As I mentioned, ejection fraction is the outlier in many cases, and this is the divider. Now, QRS duration is also a divider. There are hardly any therapy of CRT family which can benefit narrow QRS. So Barostin is another thing, CCM technology, RD and atrial shunt. But as I mentioned, atrial shunt in patients with preserved ejection fraction is not a good idea anymore. Perhaps in reduced ejection fraction still have a scope. Ablations, etc., you should continue along with the device. You know, the hot thing or a new thing is LVP zone pacing or conduction system pacing, his bundle pacing. So there are many combinations of CRT, CRTD. So these are the things which we are doing. We have an experience of having 100 cases of LVP zone pacing or conduction system pacing. It can be done with a dual chamber pacemaker, even a single chamber pacemaker after AV node ablations. So this single chamber pacemaker can work as CRT or CRT equivalent. And the basic difference between CRT and LVP zone pacing, you know, you have epicardium to endocardium activations in CRT, whereas in left bundle branch or cis bundle, the benefit is better because you are moving from endocardium to endocardium. So I have a very low threshold of prescribing a conduction system pacing instead of CRT, and it is much more economical, less time consuming, and less learning curve. And to teach others, they can pick up these conduction system pacing, which will be working as CRT, and you can combine with D therapy if somebody needs a D. Now, this can be done on your routine fluoroscopy. This usually lead is anchored here in the septum. So these are the newer things. You can see this lead is anchored here in the septum, unlike your coronary sinus. And this is the penetration of the septum. You have to go deep into the septum. Sometimes so deep you can injure the smaller coronary arteries. Now we are moving towards the Ccm therapy. It is another therapy, another device for treating a narrow QRS complex. It can be combined with the CRT. It can be combined with the subcutaneous ICD. It can be combined or given when your CRT fails to the non-responders along with your 4 fabulous drugs, IV iron, ivabradine, omecamtiv, vericiguat, or a mitochondrial transplant. These devices can borrow some time for transplant or LVAD. Now, ladies and gentlemen, let me finish here that it is a team approach. It's not that it is kind of, you have to put your patient on the other side by a team of electrophysiologists, the TAVR specialist, the good pharmacologist, good internist, good medicine, good physician, take control of your sugar, the precipitating factor, good dose, rapid titrations, and GD&T will definitely be helpful. Or if somebody needs CRT and ICD, the baseline or foundation is formed or built up by your good pharmacological therapy, polypharmacy. On the top of that, you give this clip, valve, or device, and that will prolong your life, good quality of life, prevent death, and prevent hospitalizations. Thank you very much for your kind attention.
Thank you very much, Dr. Hazrat. That was a beautiful coverage of the important devices. I now welcome both Dr. Puranan and Dr. Vivekakumar. I think both of you are there. So maybe Dr. Vivekakumar, I will take some comments from you. Without asking questions, I would just like your thoughts and about ARNI in particular, and when to start, what difficulties you find, some practical points on ARNI, if you could tell us.
Yes, so I think first of all, I must compliment all the speakers, including you. So after your talk, I don't think I have to speak much about ARNI. You have really covered it very well. So well and truly, it is a revolutionary drug. And, ARNI is something which has taken a lot of our, heart failure patient, not only off the list of CRT and ICD, but also off the list of heart transplant and LVADs. It's been really, quite remarkable. And the reverse remodeling of the heart is being, again, very, very important. And we have seen that many patients whom, we had lost the hope, they are coming up. The one thing which I would like to emphasize is that we should not be complacent in that group which you discussed, that heart failure with improved ejection fraction. That's a thing which I would also emphasize, that not only in the literature, but in our own experiences, the lot of patients where the ejection fraction has improved almost near normal, they have discontinued the ARNI and the other guideline-directed medical therapy. And then within 3 to 6 months, we have seen that the ejection fraction has gone down again to baseline 20%, 25%, and they are in frank heart failure. So I think initiation and maintenance of the therapy and up titration of the dose which has been used in the trials, that should be done. And of course, as Dr. Hajra rightly said, that the combination of all the therapies. So if you give all the guideline directed 4 pillars of heart failure medications, plus the inappropriate cases, you can give the device therapy, CRT and all, even hot CRT, or even in poor patient, appropriate patient, you can do, physiological pacing. So those are the things which are going to change the scenario. So I would say that the other important thing which has happened of late, that the indication of defibrillator has come as 2A in patients who have got dilated cardiomyopathy, not ischemic cardiomyopathy. So that's again, I would say that the power of medical therapy has gone such a big notch up, that the device's role has been coming down. So I think it's a very, very interesting time, and more and more molecule and evidence is coming in favor of, pharmacotherapy in heart failure, with all kind of heart failure, I would say.
Thank you very much. Dr. Puranan, some practical hints from you. Do you start all your patients? You run your own hospital. So how do you deal with your patients? Do you start them all on ARNI or some other drug? And how do you approach your patients? Would all your patients be on ARNI before they left the hospital? Or what stage of heart failure would you start them?
Usually patients with moderate to severe left ventricular dysfunction, if the patient can afford the ARNI for a reasonable length of period or a lifelong therapy, I try to initiate them with the ARNI in the first instance, unless until there is any contraindication or any probability of patient not being under regular follow-up, or is unable to afford the treatment for a reasonable length of time. I prefer to start them off, if especially if the ejection fraction is around 35 to 25, then that is the best patient I feel to initiate the treatment on ARNI. Unless until if the patient is not willing, then I put them on valsartan. And if patient is willing to start to make the treatment for a reasonable length of time, I prefer to use ARNI. The practical issues involved in is if the patient is already on mineralocorticoid receptor antagonist, I want a frequent potassium check when the patient is in combination with ARNI and MRI. So I make it sure that these patients have to be on a regular follow-up to see significantly. Some patients have landed up in significant hyperkalemia, leading to a lot of problems related to hyperkalemia. And when the patient is also on a diuretic, then the hyponatremia issue also has to be kept in mind and has to be followed up. So they started using it since now 4.5 years. There were some patients who almost returned to normal. I don't know if they would have done it on valsartan also, but the results with ARNI were really dramatic, and patients really had benefited when patients were directly initiated on this kind of therapy. So my experience has been reasonably good with this one, and almost more than 200 patients on follow-up with ARNI for moderate to severe LV dysfunction, who are now in mild to moderate LV dysfunction. So all patients who can afford it for a good length of time, then I thought that ARNI is a good probability. I discussed with when there was a seminar along with the pioneers of ARNI therapy. Is there any possibility of shifting them again back to valsartan if the patient has ejection fraction returned to around 50%? But they vehemently denied that if the patient again shifts to only valsartan, probably the benefits of this therapy may not last long, and patient again goes to LV dysfunction. So these are the issues which were practically discussed with the paradigm HF trial originators, original research.
Thank you.
So they have that opinion that it has to be continued for a reasonable length.
Yeah. I would like to make 2 points on that. One point you mentioned is the important point of changing maybe back to valsartan from ARNI or stopping. I think, of course, there's no trial to shift back and see whether they are going to worsen or not. But also the important point to remember is that sometimes with some of these patients who do worsen, and then you feel, okay, if they worsen, I'll restart them on ARNI. But then the ejection fraction may not improve the second time. So it's very important to remember that you cannot decide that you will stop. And if they worsen, then you will restart. And if they don't worsen, then it's fine, great for them. But because you don't know who's going to worsen and they may not improve. The second point you made, which I sort of would like to debate about, is that you said that if the patient is not willing for lifelong treatment, you would be a bit hesitant. But why wait for lifelong treatment? We know that the vulnerable period is very early. We know that after many drugs, they're not only on ARNI, there are many drugs, heart function may improve, etc. So why not start all of them, give them the benefit in the first few months, even if it's an expensive drug, and then maybe then because of very important financial reasons, if they cannot continue, then you can't help it. You could shift back to whatever you want, valsartan, etc. But I think maybe at least the first 3-4 months you could convince them to take. You think that would also be a good idea?
Yeah, yes. But that we do, preferably now we have that price concerns are also some companies have addressed. So we are mostly almost 90% of the patients have been initiated with this kind of medication, especially if they are in moderate to severe. Sir, what is the experience with post myocardial infarction LV dysfunction? Have you have any particular experience of using them in early post myocardial infarction patients who have moderate to severe LV dysfunction?
There are trials in the post-MI period which were not so successful as the Paradigm trial. There were also trials they were presented in ESC last year. There was also a trial in class 4 heart failure where also they were not very effective. So you should remember 2 things. One is that if you wait till the end stage, if you wait till end stage heart failure, when the patient is almost about to die of heart failure, starting ARNI in fact may make them worse. Because when you reach a certain point of end stage heart failure, you need that sympathetic drive, you need that RAS stimulation to keep you alive. So when you start blocking that off, patients actually deteriorate and die. So do not allow the patients. When I asked that question to the principal investigator, they said the mistake is not to allow them to reach that stage. Of course, it's easy to say that some people eventually will reach that stage. So when you reach that stage, you have to be really careful because they mostly do not tolerate when they're at end stage. With acute myocardial infarction, there's also a trial, I forget the name, which was a little bit beneficial in terms of hospitalization, etc., but not so beneficial in terms of survival. So I think what I have seen in my practice is that if you have a patient who's got, say, an anterior wall infarct, the anterior wall is all thinned out and fibrotic and almost aneurysmal, these patients don't really improve with ARNI or no ARNI. But if you have an anterior wall which is not scarred and thinned out, there is some muscle left, these patients usually improve. So obviously you got to make a correct selection of patients to benefit from that. But I think these are the subsets that I think we have to treat on an ongoing basis, on individual basis. Dr. Hazra, one question to you. This comes very practical. I, for example, had a patient today who got discharged, a young guy, 54 years old, with ejection fraction of 20%. I called my electrophysiologist. He said, put an ICD. The patient said, should I put ICD now or should I wait? He's just been started on all the drugs. How long would you wait before you put an ICD or a CRT in a patient who's just diagnosed as heart failure, has just been started on treatment? Do you have some interval before you put these devices?
A beautiful question, sir. You have to divide into 2 groups, whether he's got ischemic heart disease, and young ischemic heart disease does need ICD, even if he's not having any incidence of VT or a couplet or triplet. So there is no doubt about that. We have data on that. Now, if it is a non-ischemic, cardiomyopathy and 20% ejection fraction, even then they need ICD because of his age, which is very tender and young, I would say 57. Now, had he been from 5'7" to 7'5", like elderly, then there is a question mark on 20% whether. So age is definitely one of the threshold, and the ischemia and non-ischemia is definitely another outlier. And the ejection fraction, if you go down with the ejection fractions, the chance of sudden cardiac death goes down. So the value for money also increases. If you combine ICD with CRT or LV vision pacing or hot CRT, if their QRS is little wider, if they have interventricular conduction defect, if they have even RBB, they will benefit from ICD plus something. If the QRS is very narrow, then perhaps he needs ICD plus CCM technology or other like a baroreceptor. Those things are coming for the future. And you have to invite other drugs as you are a proponent for Berisogard. We have discussed many times the newer drugs should be given in these moribund patients. As we are mentioning the Paradise AMI trial, in MI, it doesn't help. So if your ejection fraction is 20% immediately after myocardial infarction, these are not the patients for your ICD. Even you have to wait for 42 days. But if he is not ischemic and he has crossed 42 days, they need definitely ICD.
Good. Thank you very much. So that clearly gives you an idea of when to do this. Dr. Ponde's left us. So Dr. Vivekakumar, back to you. There's a question out here saying, would you use ARNI in patients with postpartum cardiomyopathy? So is there any specific cardiomyopathies where you would use and where you would not use, or over the board for everybody?
Yeah, so I think this is over the board for everybody. So in fact, if you see the ejection fraction, which is low, so even in patients who had heart failure with preserved ejection fraction group also, numerically the ARNI did benefit, though it did not reach the statistical significance, and that is why in FDA approval also it is there as a approved drug for heart failure even with preserved ejection fraction. And cause of low ejection fraction or heart failure, irrespective of whatever the cause is, it is all the spectrum. So even in peripartum cardiomyopathy, in fact, we have been using it quite regularly in peripartum cardiomyopathy, and it has got good outcomes. So I would say that it's across all the spectrum, irrespective of the cause of the low ejection fraction.
Thank you very much. What about potassium problems? We discussed hypotension, but I didn't discuss potassium, which I should have. So let's bring that up. Potassium is another issue, rising potassium with ARNI. How do you deal with rising potassium, and what do you do with these patients?
Yeah, so I think the important thing is that we need to sensitize the patient. So diet plays an important role. So the kind of lifestyle they take, and so in our country, if you say somebody that you have got weak heart and the patient is sick, the relatives and the family would keep on giving them a lot of coconut water, bananas and fruits and juices and also because they feel that probably that's the best thing to give. So if we try and be selective and tell them that these are the potassium rich diet, then we should be avoiding them in plenty. And then the combination of the medications also play a role. So we need to give medications which do not cause cumulative potassium rise, and especially we need to be very careful in patients who have got chronic kidney disease. So those are the patients who would be selectively getting more potassium retention than the other group of patients. And remember, there are a lot of these FF patients who are cardiorenal syndrome patients, so who have got concomitant not only the severe heart failure but also the renal dysfunction. So the trick is that we need to before we start, we need to have a baseline value. We need to look at the EGFR. We need to look at the potassium and electrolyte levels. And then when we are combining either you go by, what we call, early initiation of all the medication. There, when we combine the group of drugs, which are like ARNI with MRA antagonist and or even for the ACE inhibitor ARV group of medication with the MRA antagonist, then we need to really be careful and we should try and see what is the potassium level, and after that we need to recheck it after 3 to 4 weeks just to see the potassium is not. So once they tolerate the initial onslaught, maybe 3 to 4 weeks, then we have seen that they maintain a good potassium level and we don't have to be really worried about. But in between, if they have got deterioration in renal function or dietary variation significantly, in that place we need to really educate them. So I would say that diet and very small things do matter a lot, even when people don't realize that when the patients you give diuretics and all, their sodium level intake goes up. Even if they are taking processed regular bread, there also the sodium level is high. So the diet information has to be given to the patient, and I think 99% of the time we can bail out them from risk of getting into significant hyperkalemia.
Again, the good thing is that we know that when SGLT2 is given with ARNI, the hyperkalemia is less. So that's big advantage of combining the two, so you don't get so much hyperkalemia. Also in ACC last week, they had a trial of using Pateromar with ARNI, and they found the large number of patients did not get hyperkalemia when they were given Pateromar. So I would request Reddy's to please bring Pateromar to our country, so that it's a great drug. It's been very useful. Now we got this new trial in ACC also. It will allow us to give a much better dose of ARNI, because many times it's the hyperkalemia which prevents us from increasing the dose of ARNI. It's a hypotension and the potassium which create problems in terms of increasing the dose, which is why large number of these patients are left on 50 milligrams. Having said that, we also know from trials that even small doses are better than nothing. So if your patient's on 50 milligrams, it's fine. If the patient can reach 200 twice a day, even better. But even 50 milligrams twice a day will be beneficial for these patients compared to no. But if you use Pateromar along with these patients, then you can increase the dose without worrying about the hyperkalemia. So I think that's an important point to mention. Dr. Puranan, about sequencing the patient. I mean, there's a lot of question about which drug you should start first, ARNI or SGLT2 or beta blocker. We know that Dr. McMurray has suggested some therapy, others have suggested other. What is your take on that? Then we can take Dr. Hazra's view on that as well after that. And please speak a little bit louder, Dr. Puranan. Last time I had a little difficulty in hearing. We can't hear you.
I think he's not there.
We can't hear you. You're on mute. Yeah.
So regarding
please speak a little louder, please. Yeah.
Initiation, I am a bit so I'm not very keen, because especially if he's not a diabetic patient. So I prefer to initiate on ARNI first, and if he's a diabetic patient, they're looking at his blood glucose levels, I prefer to start on SGLT2 inhibitors. So the trials say that they are the first drugs to be started along with beta blockers because they have shown the mortality benefit. Still, I have my reservations of using SGLT2 inhibitors primarily in management of heart failure, based upon the profiles of the patients, what I see. So if he's a diabetic, I'll be keen to initiate SGLT2 inhibitors at the earliest. But if he's not a diabetic patient, I still have reservations about using them in these kind of patients.
Again, if I may have a sort of a difference of opinion on this, this is what I do. Of course, we'll take Dr. Hazra's view and Dr. Vivek Kumar as well. The reason why Dr. McMurray suggested SGLT2 was, number one, it does not produce the hyperkalemia. Number two, it produces less fall in blood pressure. And therefore, when you have these patients with CKD and hypotension, SGLT2 is better tolerated. Whichever SGLT2 inhibitor you use, better tolerated because it doesn't produce the hyperkalemia and hypotension. So which is why his preference for first use of SGLT2. Also, the suggestion that these patients had just come out of heart failure, they still had fluid retention, and some of the diuretic effect of the SGLT2 in the initial period may also help these patients to be less breathless. And you mentioned also about diabetic patients, but I think non-diabetic patients we know very well are equally benefited compared to diabetic patients. And in fact, to be honest, I find it easier to treat non-diabetic patients because then I don't have to bring my diabetologist into the picture. And secondly, the sugars don't become a problem. We know very well that when we use SGLT2 inhibitors, it does not produce hypoglycemia even in non-diabetics. So my personal feeling is that diabetic or non-diabetic, SGLT2 has an important role to play. Now, whether you start SGLT2 first or ARNI first is debatable. As a cardiologist, I like ARNI because ARNI produces much better improvements in ejection fraction compared to SGLT2. I mean, clearly we've seen that, and therefore I prefer that my patient must be on ARNI and then yes, no for SGLT2. I personally prefer, like some of the Americans suggest, that it's better to start small doses of all the drugs and let the patient go home on small doses, so then you can increase the dose as required depending on what the patient's problem is, rather than on one drug. And I know that Dr. McMurray said, call them back after a week, add this, then again week, add that. But that may not work out in our practice. We may tell the patient come after a week. Suppose he comes after a month. Then the first 4 weeks of very vulnerable period, your 4 pillars will not be on the patient. So my personal preference is small dose of all the drugs and then gradually build up. Dr. Hazra, your opinion on this sequencing, and then Dr. Vivek Kumar.
Yeah, as I have shown my slide, that I do not believe in this step care approach anymore. As you are suggesting, all these drugs can be accommodated in most of the patients in an acute setting, even in valvular heart disease without significant mitral stenosis, heart failure without knowing the ejection fractions. All 4 drugs can be accommodated, as you have mentioned. Start slow and start low, go slow with any drugs, and you build it up. So you can go for escalation and de-escalation depending on your hemodynamics, potassium. If you have a high potassium, go for de-escalations. But for me, all 4 drugs can be instituted. You can start from SGLT2 because on the very first day, they are on GDNT, 1 dose once in a day, rather than 3 different doses like beta blocker. You have to titrate them, you have to monitor them. And this is a kind of genre of SGLT2, but you have different varieties, different genres of RAS inhibitions. So I will go by 4 foundational drugs in the first 4 weeks. All 4, you can start with anything, but preferably SGLT2, then ARNI, because the side effects due to SGLT2 in acute setting is very minimal. There is no hypertension, and you don't have to monitor their potassium. But it is very easy, available, very attractive for all heart failure patients. Thank you.
Dr. Hazra, you made a very important point. You said you would start the drugs irrespective of the ejection fraction. I think that's very important because that's the way we are moving today. If you look at the Emperor Preserve, it clearly showed that even with ejection fractions, which were 50%, these patients benefit. If you look at the Paragon trial, the group of patients with the mid-range, somebody's asked what is mid-range and mildly reduced, it's the same. Mildly reduced is what is the new terminology, mid-range was the old terminology. And these patients also benefit with the use of ARNI. Female patients also benefited a lot with the ARNI, even with good ejection fraction. So I think heart failure is a clinical diagnosis. Don't go only by ejection fraction. We know that SGLT2 benefits the middle range group. We know ARNI benefits the middle range group. So clearly start off on all the drugs. Do not hesitate because the patient's ejection fraction is 48% instead of 38% or not 48 and all that. So don't get too carried off by ejection fraction. We also know that ejection fraction is a very not a very accurate measurement. It's an approximation. We know that different doctors may give different ejection fractions. So don't get too caught up with ejection fractions. I think just start the patient. So Vivek Kumar, what do you do in terms of sequencing? Your personal view.
Yeah, so I would say that, I fully agree with the approach where all the drugs in, smaller doses to begin with and up titrating gradually. And then obviously it's easier in patients who have got good blood pressure on the higher side, who can tolerate, so you can up titrate in much better way. Having said that, those patients who have got, cardiorenal syndrome, the creatinine is bothering you or the blood pressure is on the lower side, and they don't tolerate initially the hypotension of ARNI, then I prefer to straight away go with the SGLT2 inhibitor and the beta blockers and also whatever he tolerates, that's better. And in couple of weeks or months time, they are in a position where they would tolerate ARNI. So I think the maximum number of pillars the patient can get support from would be the ideal way to go about. And the same would be that up titration of the doses, what has been used in different trials. I fully agree with you that the patients who are non-diabetic, they would be doing better, and data also shows that overall outcome of patients who are non-diabetic, they get equal amount of benefit from these 4 major pillars of the heart failure treatment. At the same time, their outcomes are also much better. So those patients who have got significantly higher blood pressure, they have been taking, I think you also mentioned in your talk that there are patients who are taking amlodipine, and on the other hand, ARNI in 50 milligrams twice a day dose. I think that's quite ridiculous. We need to straight away up titrate the dose of ARNI rather than giving them prazosin or amlodipine and these drugs which do not have significant improvement in outcome as far as the heart failure patients are concerned. So I would say that we need to go cautious, and there are few questions also that what do you do in patients who have got acute MI or those who have got acute decompensated heart failure. There are a lot of data of good outcomes in acute decompensated heart failure which has improved, and then whether you need to start ARNI and then go about that. And considering the post-MI situation, the ARNI, it was not that the ARNI was harmful, but it did not meet superiority over the ACE inhibitor. So I think if the patient is already put on ARNI, there's no need to stop. So the message should be that it's as good as ACE inhibitor in that situation also. So I think that is my approach in different sets
Dr.
of
Dalal, there are some concerns from our side, like what should be the maximum duration of therapy? What's the safety for the longest duration of treatment with the ARNI? And is there any need for 25 mg? Instead of patient being withdrawn from the drug once the ejection fraction improves, is it prudent to go for the lowest dose and maintain patients at the lowest dose of ARNI? So if you can get...
Yeah, we take Dr. Puranan's view on that. Puranan, what's your view on 25 milligrams and shifting down? You mentioned that also down titration to valsartan. What about down titration in terms of dose of ARNI and other drugs? Your view on that?
Sir, I don't think, sir, down titration will be of much use, because with ACE inhibitors, statins, and these kind of drugs, the higher the dose, the better the results are, and especially at the cellular level and at the remodeling level. So giving an appropriate dose for a reasonable length of time is the most important than giving a very small dose and expecting the results to happen. So I don't think even 50 milligrams is a very minimal dose, because the trial results are better off with 100 milligrams PD and sometimes 100 milligrams PD and probably 200 milligrams PD also. So I don't think 25 milligrams will be of much importance or of much use in the regular day-to-day practice. And when the patient gets benefited with the treatment and if there is scope for up titration, I prefer to up titrate than down titrate the patient for a better long-term results. The only concern was the financial concern, for which I asked the principal investigator that only valsartan can be benefit over on a long-term basis, but they said that it is not a good option to down titrate it to valsartan. So I feel that if the patient gets benefited with 50 milligrams, if you have an opportunity and if there is blood pressure and every other parameter is allowing us to up titrate, it is preferable to be up titrate for getting better results for a long period of time. So I don't feel that down titration will help with it.
I think
what's the safety for
having 25 milligrams, but you can always break the tablet into half if you need the 25 milligrams. A cost saving for the patients of getting another 25 at the same cost as 50. So, and do we use 25? Yes, sometimes we are forced to use 25 milligrams. Suppose you have a patient. I have a patient just now in my hospital. He's 80 years old. His ejection fraction is 20%. I put him on half twice a day of 50 milligrams. So 25 milligrams twice a day. And within 24 hours, his BP dropped to 82. And of course, I had to withdraw it quickly because he was feeling very dizzy. So there is no harm in starting with a small dose. Let's be frank, but try and increase the dose. Don't keep him at that little half dose and forget about it. Because the important thing is that we increase the dose. There is a sub-study of the Paradigm trial which shows that the bigger the dose of ARNI, the greater the improvement in ejection fraction. So the more dose you use, the better the improvement in ejection fraction. At the same time, even a small dose is better than no dose. So if you want to use 25 milligrams, you are worried about the patient's blood pressure, kidney, whatever, go ahead and use 25 milligrams, but then gradually try and increase the dose as much as possible. When you get a nice improvement, don't start dropping the dose too much again. It's like statin. You get a nice reduction of your LDL to 40, and then you want to reduce it down and let the LDL go up again to 60 and 80. That's not necessary, and it's harmful for the patient. Dr.
Dalal, any experience on the how long it can be given, like safety for the long-term duration?
There is no problem. I don't think anybody's spoken about long-term harmful. Anybody else, Dr. Vivek Kumar Hazre, any worry you have about long-term? I don't think there's any concern about long-term. We've been using RAS blockers, AC inhibitors for decades, and there has been no long-term problem. So I don't think there's any long-term concerns about ARNI. I think we've already been using it for 3-4 years, and there has not been any issue. So in my opinion, there doesn't seem to be any long-term problem. Dr. Hazra, Dr. Vivek Kumar, any thoughts on long-term problems?
No, so I think I fully agree that it is something which has to be given lifelong, because there is enough data to suggest that if you discontinue, then again there is a drop in ejection fraction and symptoms and all. So I would say that it's a molecule which has to be given long term, And unless we are intervening with some other modality of therapy like heart transplantation and so on and so forth, or some new molecule comes which is more powerful than this. But this is the molecule which has to be given to my understanding long term and maybe lifelong in patients, where because unless you revascularize, heart failure is not going to get controlled. So those patients who are not revascularizable, normal redirected cardiomyopathy patients, or those who are already been fully revascularized, there is no other scope of improving the ejection fraction except for these kind of therapy. So this is a long-term, lifelong therapy.
And Dr. Dalal, one concern that was there from beginning was because Paradigm trial has taken ejection fraction less than 40 as inclusion criteria. So between 40 to 50, still, do you think it's because it's a mildly reduced ejection fraction, the drug will still have a place in those patients with a mildly reduced ejection fraction?
The Paragon trial showed that if you subgroup them, of course, not the aim of the trial, if you subgroup them, then they benefit. If you look at Emperor Preserved, actually they took all these patients and they called it preserved ejection fraction, but actually their patients were in the mid-range ejection fraction, mildly reduced. So I think mildly reduced ejection fraction behaves the same way as reduced ejection fraction and should be treated the same way. I would also like to make one point that many of these drugs are also used prophylactically in patients going for chemotherapy, which produces chemotherapy-induced cardiomyopathies. And there's some data coming on that any of these drugs may also have benefits. So I don't want to go into that. What I would like to do is to end now, because when I say we should start on time, we should also end on time. And I think we are now past 9 o'clock. So I think I'll thank all my speakers for having given a wonderful talk. We missed Dr. Ponde, of course, during the discussions, but I think he gave us a brilliant talk. So I would like to end by saying that ARNI is an extremely useful drug. Please use it for all your patients with clinical heart failure. Don't restrict it to patients with ejection fraction only less than 40%. Anybody, even in the mildly reduced, will benefit them. Once they improve, do not stop the drugs. Try and combine with all the other drugs, including SGLT2 and beta blockers and mineralocorticoids. Patients will dramatically improve. The unfortunate and the most unfortunate part is that somehow there is an inertia of not using these drugs or not using them adequately. Very important to have a checklist which you must make in your hospital or in your clinic or in your office. Have a simple checklist which contains all the drugs, which drugs are given in what dosage, why they are not given in case they were not given, and dosage is important so you can improve the dosage. Add things like vaccination, add things like cardiac rehabilitation, add things like iron management, add ICD, add CRT. So the checklist will make sure that you're not missing out anything and you're optimizing the treatment of the patient. So I think I thank everybody once again, and I think we'll end this session. 1.5 hours is a great amount of discussion, great learning on heart failure, but I think it's time to now say thank you and goodbye.
Thanks a lot, Dr. Dalalia. Thanks a lot for this wonderful discussion. I thank all the speakers, especially Dr. Dalal for this excellent moderation for the whole session. I would like to now invite Neeraj for closing the section.
Thanks, Mustafa sir. Not taking more than half a minute. I would first of all thank you for moderating this session and giving your sharing your experience with ARNI as well as treatment of heart failure, along with the Dr. Viveka Kumar, Dr. Purnanand, Dr. Hajra, and of course Dr. C.K. Pandey. Also, sir, I would like to thank close to 900 plus cardiologists and physicians who were listening the session and getting enriched with your experience and knowledge sharing. From our side, sir, we have SIDMUS, and this is one of the strategic move to have our presence stronger in cardiology segment, and definitely with our strong distribution and supply network will make the drug available to every nook and corner of the country. Also, sir, we have integrated our backend functions. So as soon as the drug goes off patent, we'll make sure that drug is affordable and accessible to every patient wherever he is coming from to consult with you and goes back to his hometown. With that, sir, I would again thank you so much for sharing your experiences.
Thank you very much. Bye-bye, everybody. Bye.
Thank you. Thank you, sir.
Thank you.
Thank you. Thanks, sir.
Hello. Hello.
Yeah.
Brijesh, thanks, yaar. Yeah. Flawless tha, badhiya tha. Yeah, we can close the session.